plus navigating the healthcare experience. Thank you.
Well, hello, everyone. So it was great to follow up on that talk because a lot of the work I have today is actually completely blanketed by recent federal policy changes in research. Reiterations, let's just say that for now. So I'm Miria Kano, as I was introduced. I'm an associate professor of community and behavioral health, medical anthropologist by training, and I am also the associate director of the Office of Faculty and Staff Relations at the University of Colorado Cancer Center. And I'll figure out how to use this thing in a second. There we go. So full disclosure, I don't have any financial things to disclose about this. However, I'm part of this community, been married to a woman for a long time. We're raising 2 well-adjusted, healthy, happy, heterosexual daughters, so no, it's not contagious. But for today's talk, I'm speaking from my own witnessed research experiences. I've worked with this community for more than 20 years. The research presented here was not funded by the University of Colorado, and the study was conducted at another institution prior to modifications to federal policies and research priority changes. So there you go. But given that, I think it's extremely important to have this talk today, because even if the federal government, other people would like to say very much the same way they have with other policies, that if we just make LGBTQ people illegal, they don't exist, we know that that's not true. We also know that even if we aren't allowed to proceed with research to document any of the disparities that the LGBTQ community experiences, we know that from 20 years of research that these disparities do exist. So a lot of the work that's been moved forward, and the reason I'm excited to talk to this group, is that people in your positions are the people that have made all of the positive changes that have benefited LGBTQ people that have cancer and are recovering from cancer. So we know from previous research that national level organizations like the Institute of Medicine, American Society of Clinical Oncology, have documented several disparities: a lack of LGBTQI cancer research, and from now on I'm just going to say SGM for sexual and gender minority because that's really hard to say over and over. We also know that there are lower rates of cancer screening in this population. We know that there's less and lower satisfaction with cancer treatment, higher rates of psychological distress and survivorship when compared to heterosexual and cisgender counterparts, gaps in patient-provider communication, body image issues and eating disorders, particularly among transgender and gay male populations, and then also health and behavioral health problems for all SGM people who have experienced violence, whether that violence is sociocultural violence, verbal violence, or physical violence. We also know that there are elevated rates of certain cancers for the SGM population: anal, breast, cervical, colon and rectal, lung, and prostate cancer. And then we also know that there are cancers associated with gender reassignment surgeries, as there are with other types of hormone replacement therapy type involved cancers. So we know that these rates are elevated, and so we've done a lot of research to really address these things, and now a lot of that research has come to a screeching halt, and a lot of people have lost their funding. I also feel it's really imperative to talk about SGM elders in this context because the majority of people that have cancer are our eldering populations. So for LGBTQ populations, we know that there's 1.1 million SGM adults in the US today that are over 65 years old. We know that they're twice as likely to be single as when compared to heterosexual cis populations. We know that there are 3 to 4 times less likely to have children to support them. We also know that 1/3 of LGBT adults live in poverty. They're twice as likely to live alone, and they also are much less likely to disclose their sexual orientation when they're in treatment for fear of stigma and discrimination. This work remains important, though, because as I mentioned earlier, this population doesn't go away because it's not in vogue anymore politically. Last year, the 2024 Gallup poll indicated that now 9.3 people in the United States are identifying as lesbian, gay, bisexual, transgender, or something other than heterosexual. So what we know about that is that 20 years ago, they told us it was 3.5% of the population, and that held for about 10 years. Now it's just rocketed up in the last 4 or 5 years, partially being driven by our younger and middle-aged respondents to the Gallup poll. What that also tells us is if they're the one pushing this up, the elder LGBTQ folks are still not counting themselves on this Gallup poll. So this number shows us that there's this upward trend, but it still doesn't capture the total reality of the LGBTQ people in the country. So I have several studies in this area, but I wanted to take this back to a 2022 pilot we did that was funded by the American Cancer Society. For this multi-methods research project, we recruited 40 cancer patients and their self-identified primary caregivers. Half were SGM and half were heterosexual cisgender. We conducted qualitative interviews that lasted, we said, it's gonna take, an hour. Every one of those interviews was 2 hours. I'll just say that right now. Everyone had so much to say, and just having the time to have someone sitting in front of them talking about their sexual orientation and their cancer and how those things went together and how that impacted their care, their outcomes, their lives, people really, wanted to be involved in that. Patients and caregivers also completed PROMIS, Validated Measure Quality of Life surveys for us, and so we had 40 people total. Every one of the LGBTQ patients and caregivers who responded to our interviews had all experienced some type of anti-LGBTQI stigma and discrimination. Verbal assaults, loss of jobs, bathroom policing, loss of child custody, house purchase issues, structural traumas stemming from the AIDS epidemic, politics, marriage exclusions, and being hiding and being closeted, particularly for those who are in the military. So I wanted to just bring in some patient voices to kind of talk about why this is important and what this says when people are actually in cancer care. So one lesbian caregiver said, I'm 80 years old, so I go way back. Being gay in the 60s and 70s was really scary, especially in the military. If you even had a friend who was gay, you could be discharged. It was very difficult to hide that. Every day you're living a lie, every day you're living in fear. Another lesbian patient said, I've always looked over my shoulder. I've always monitored what and how I say and how I behave. I never felt totally safe. That's just how it is. And then another genderqueer patient told us the part that's toxic is you always have to wonder. Just the fact that you even have to think about it is kind of where the toxicity comes in. And their point was that, you never really know if someone is holding some type of, stigma or discriminatory attitudes about you unless it's super overt. And most people, she says, are smarter than that. They do things in a more subtle way. We also know that all of these situations lead to what we consider conditional openness with regards to their cancer care. So a gay patient told us it's not consistent being able to be out. It's been challenging to come out to certain people, doctors. Another gay patient said, it's just such a big and integral part of my life and that it's never come up. And this is a patient who has a chronic cancer condition and has been working with his cancer care team for 8 years. So that's not good. He can't talk about who he is. No one's ever asked him why he always has random different people coming in with him all the time. So these are the things we need to think about, like who are the people in front of us and how can we improve their care? And then another lesbian patient said, they think my wife's name and I are sisters, and lots of the time we just let them think that. These two, one was 81, one was 85. They've been together for 42 years, and they aren't open with the cancer care team because they don't feel safe. So Basically, they just allow people to call them sisters, and that's how they've navigated it. And when I tried to talk to them, would you like to do that differently? And they said, of course, but they didn't trust it. They don't feel like they'll get the same level of care if they tell people they're lesbians. So when we think about conditional openness, what we're really referring to is the fact that when your patients come in, the way age, generational social norms, and prior experiences come together really kind of catalyzes the patient's ability to either tell you about who they are or not tell you who they are. So for a lot of our older patients, they just simply don't. That's not true of all. Any of them, a lot of our patients had activism in their backgrounds. They were much more likely to come out and talk about it. Patients, and I know this is not going to be a surprise to anyone, if they were patients who were LGBTQ and people of color or lived in a rural area, much less likely to divulge who they were and to talk about the totality of their identities and how that affected their cancer care. So why is this important? Because patients do not receive equitable care if they don't feel comfortable being open about their lives, their family, and their friends. LGBTQ caregivers are not the same as heterosexual caregivers. They tend to be younger. They tend to have known the people less for a shorter amount of time. And they're generally not their family of origin, because a lot of people have actually lost their family of origin when they came out of the closet. So these caregivers may look different, they may seem different, and they also know that they won't be treated the same. So there's a barrier even when they come in. So this genderqueer patient and their wife said they sat down with their oncologist and said, we asked our provider, are you okay working with a lesbian couple? Because neither of us really trusted that she or any medical professional is. Because people have all kinds of stuff. There's a lot of religiosity, even among doctors and healthcare professionals, where they have biases, and those biases come out. We wouldn't have had to do that if we were a straight couple. So they basically had to interview their oncologist to see if they could even get cancer treatment. So caregivers, likewise, if they don't feel seen or included, may not participate fully in their loved one's cancer treatment recovery. And we know that's important because I interview cancer survivors. This is one leg of my work, but my work is cancer survivorship broadly. And patients tell me all the time, well, I don't really even know about those first few visits I had. You're going to have to talk to my spouse, my caregiver, whoever was there, because they're so traumatized by cancer and that diagnosis that they're not present enough to hear all of that. So if the caregiver doesn't feel like they're welcome in that room, they're missing out on that vital support that really leads to more positive recovery outcomes for cancer patients. So one caregiver told us, I didn't feel seen. I kept trying to connect with the doctor in a way that would validate me, acknowledge me. I said, I work in the hospital. I know the system. I lost my sister to cancer, and I was her caregiver. But I never got recognized as someone. It wasn't worth fighting to try to impress my point. I just held on to my observation. I walked out of there feeling like I did everything but stand on my head to get acknowledged as somebody. It made me so angry. And it made her so angry that she barely made it through the interview with me because she was just like, stressed because her wife has cancer, angry because she doesn't feel like she can help. And, it's a very powerless feeling for anyone. So why is this important? It's important because there's observable differences between SGM patients and cisgender heterosexual patients and caregivers. So we really looked at 3 domains, physical health, mental health, social health, in terms of their cancer. And what we found was that there were definite differences. LGBTQ patients and caregivers had much higher levels of anxiety, much higher levels of depression, much higher levels of depression, but they had higher levels of companionship. Our heterosexual cis patients, on the other hand, and LGBTQ, much higher social isolation scores, which I think makes sense given everything else. So our heterosexual cisgender patients talked about having fatigue, pain intensity, and pain interference. So it's a totally different way of describing one's experience of cancer and how all of it manifests and what they need to work through. So we asked everyone that we talked to, what can we do? How can we improve this? What is it that you want? And they said, we want trained staff and providers. We need training for doctors and front-end people. Not all of them. We have run into some remarkable clinic people, doctors and nurses. The best thing you can do is bring the best of yourself to it. Some of us have to work hard on that, which I thought was a really gracious way of saying some people are just not nice, friendly people that they have to work with. They also want to feel welcome. They want to just make sure it's inviting for people who are queer, transgender, gay, and lesbian, and that it has to be real. They said, I know businesses have tried to go through a training and put up a sticker, but it has to be lived. So they're really looking for authenticity and integrity, like I think anyone is when you're there and you're vulnerable and you're hoping that you're connecting with someone or not going to be judged. They also wanted for staff and providers to ask who the people are that are with them. So they knew that she was my person, they just didn't know what to call her. That one thing was always a little awkward. Is she your wife? Is she your partner? Is she your spouse? I think it's the easy way to do this is just ask at the beginning. How should I refer to you? Just like you would ask someone's pronouns. And I can say that that is very true. And what we don't think about, my wife, just to go a little personal, had a tumor that burst. And we were they didn't know what it was because we didn't know she had the tumor, right? So we're in the waiting room and the emergency room for 12 hours before we got in. And then every person that talked to us, no one wrote it down. So every time for that 24-hour period that we would encounter them, they would say, are you her sister, cousin, aunt? And then after the 24-hour period, I must have been looking really haggard because the nurse says, are you her mother? And I said, I feel like it at this point, but I'm not. And I said, I'm her wife. And that nurse actually ended up being someone I totally adored. She wrote it huge on the board inside the room. And no one made that mistake afterwards because she was like, why isn't it on there? I had talked to probably 50 people at that time, and no one had included that. You know, little things like this make a difference. So if you're interested more in that study, because I have a really short time, I'm probably way over already, we did publish this, so it's in Frontiers in Oncology, and feel free. I'm also happy to talk about any of this if anyone wants to know more. But things that we would have said previously, increase nonverbal cues to foster inclusive environments. I know that some hospitals aren't allowing people to have rainbow lanyards anymore, so we have to be a little more creative. There are like cancer ribbons that have all of the colors, and some people think that those mean that's all cancers are included, but it also means LGBTQ cancers. So, that's a way. You could say this represents all cancers, not just, queer people. They're taking away unisex bathrooms and pronoun badges as well. So, but I encourage you, please be creative because those nonverbal cues, people thought that the institution I was conducting that study in was LGBTQ affirmative because they saw my flyers recruiting for the study. And that made a difference, just seeing a flyer with a rainbow flag on it. They instantly felt more comfortable. We need to enhance our communication strategies. If you have a toolbox about how to ask questions, it makes it a lot easier. And what people also need to know is LGBTQ people, particularly trans people, they're used to people getting it wrong. They're not really going to get upset. If someone just says, if you misgender someone and then you say, oh, I'm sorry, just say thank you for correcting me and move on. They don't want you to stay on that. They want you to just be like, it's okay, acknowledged, all good. Because that's not actually why they're there. They're there for something else. And they're, as I said, very used to it. But you can think about how would you like to be addressed? What name would you like to be called? Can you tell me about your partner or relationship status? Who's here with you? There's a lot of ways we can talk about it and include other people. And then I really encourage people, I know it's challenging, to include these on electronic and written health records. As I said, just writing at the top, how much easier does that make it, right? It's right there. That's who this person is with them. And it lets us know who it is. I also use this when working in palliative care settings. I say, if you have time and it's a chronic patient that you're seeing all the time, map the family. It's so easy to do. And then you know exactly who it is that you're talking to, who's coming in, what they do, what the relationships are. This is really important, particularly if someone has an end-of-life situation. I can give an example from a palliative care department where there were 2 men that were there. They had been married for 40 years. One of them was Chinese, and the parents were in China, so they were never out to the parents. So the parents came in, and the parents wanted to handle all of the final decisions, not his husband of 40 years. But, that man was so gracious. He was like, let them do it. But that's a really hurtful situation, to be in that and not be recognized. And if we had had all of that information up front, it would have made those interactions much smoother. So I just want to say thank you to all of our co-authors, team, and funders. I've put them in the closet to protect them. And the American Cancer Society has been amazing. So has the National LGBTQ Cancer Network, PIRE, and the NIH. For me now, talking to you at this point, I feel like your role as people interfacing with patients is so important right now. Even if we can't do things in this kind of broad policy-driven way or research-driven way at hospitals, we can do them in one-on-one interactions. And, I really, anxiety and stress levels have increased dramatically with anti-trans policies that have been, that we now have in many states in the country, and research exclusions. And I feel really lucky to be in Colorado because we have people here who are actively working on policies specific to this area. But, again, I think our one-on-one interactions and our ability to have a community is really what will get us through. So thank you.
Perfect. Thank you so much. We're going to hold off on questions just for time purposes.